Hello, welcome. Hi, everyone. Thank you all for coming. This is, I think, as you know, the first in a series of talks that WBUR is holding, and we're calling them Get Educated, so we can hopefully shed some light on some of the issues in the presidential campaign. Tonight's issue is a really easy one. Healthcare, and so we're going to be talking with our very knowledgeable panelists about the issue of healthcare in the presidential campaign, and really hoping that it will help you decide on how you feel about the issue, perhaps on who you vote for, and that's our role here at WBUR is hopefully to help all of us be better informed about the issues in our world. And I just want to tell you that there are more of these events coming, and you can go to wbur.org/cityspace to find out about all of the events that we're holding regarding the presidential candidates and the issues in this campaign. So thank you again. We know that healthcare is, if not one of the most important issues in this race right now, that voters say that they're concerned about. We know that people are very anxious about higher medical bills, higher costs of healthcare, and we know that people want something to be done about it. Not quite sure what they want, and of course the candidates have different ideas about that. So we're going to talk about these, and I want to play a little bit of tape of what we've heard on the campaign trail so far from the candidates regarding their plans. So the plan that would probably involve the most ambitious changes to healthcare is what's called Medicare For All. Vermont Senator Bernie Sanders is the biggest proponent of this. He's authored the bill in Congress, the Medicare For All bill, and he spoke about it during a rally in New Hampshire last fall. Let's listen to a bit of Bernie Sanders.
Healthcare is a human right, not a privilege. We talked about ending the international embarrassment of being the only major country on earth not to guarantee healthcare to all people. And we said maybe the function of a rational healthcare system should be to provide quality care to all, not make $100 billion in profits for the drug companies and the insurance companies.
Okay, that's Vermont Senator Bernie Sanders. Our Senator, Elizabeth Warren, co-sponsored Sanders' Medicare for All legislation. She has a similar plan, but it differs in how Medicare for All would be implemented and how it would be funded. Here's what Warren said about that recently when she was in Iowa.
We can have Medicare for all without raising taxes 1 cent on middle-class families. And it's all fully paid for by asking the top 1% and giant corporations to pay a fair share.
So that's Sanders, that's Warren, but we have many of the other candidates advocating for what they're calling a public option. Of course, they differ on what that means, how that would be paid for, what it would cover. I know it's complicated. I said this was an easy issue. I didn't tell the truth about that. Former Vice President Biden is in this camp. It's considered a little bit more moderate than Medicare for All. And he has talked about this at length, but he's also criticized Medicare for All, and in particular, Senator Warren and her cost estimates. This is what Biden said.
She's making it up. Look, nobody thinks it's $20 trillion. It's between 30 and $40 trillion. Every major independent study that's gone out there that's taken a look at this, there's no way, even Bernie, who talks about the need to raise middle class taxes, he can't even meet the cost of it. Look, we don't have to go that route.
So that's a big argument. Too expensive. We can't do it. Another candidate advocating a more moderate position is South Bend, Indiana Mayor Pete Buttigieg. And here he is talking about his plan on ABC's this week. And he said this back in November. Let's listen.
I'm proposing Medicare for all who want it. Now, if we do that, that's the biggest change in American healthcare in 50 years. The difference is the way I would do it, you get to keep your private plan if you want to.
Okay. So that's just a sampling of the candidates right now. So we got Medicare for All, Medicare for More, Medicare for those who want it, Medicare X, Better Care. Is your head spinning yet? So that's why we're here tonight, to hopefully clarify some of these issues. And I just want to let you know that we'll talk for about 45 minutes or so, and then we're going to open it up to your questions. So think about what you'd like our experts to answer about healthcare. So let me introduce our panelists tonight. John McDonough is with us. He's a professor at Harvard T.H. Chan School of Public Health. He's former executive director of the Massachusetts Consumer Health Advocacy Organization, Healthcare For All. In that role, he worked on Massachusetts healthcare reform law, and if that wasn't enough punishment, he was also senior advisor on national healthcare reform and worked on the Affordable Care Act, or Obamacare. John, thanks for being with us. Also, Steffi Wohlhandler is a primary care doctor, a lecturer in medicine at Harvard, and distinguished professor at the City University of New York's Hunter College. Dr. Wohlhandler co-founded Physicians for a National Health Program. She's also worked with both Senators and Warren on healthcare issues, but right before the event, she pointed out that those were unpaid positions. Dr. Wohlhandler, thanks for being with us at City Space tonight.
My pleasure.
And also, our third panelist is Michael Astor. He's an attorney. He's former general counsel to the Federal Health and Human Services Department, former Social Security Commissioner. He also worked in the biotech industry and is former chair of the Mass Biotech Council and on the board of the National Alliance for Hispanic Health. Welcome. Okay, so Steffi, I think I'm going to start with you because Medicare for All has been such a big topic of debate among the candidates. How would you describe this plan and how it would change our current system?
Well, under Medicare for All, as described in the Sanders bill, which of course Senator Warren has also signed off on, all medically necessary care would be available to all Americans. There would be no co-payments or no deductibles for medically necessary services. This is not pie in the sky. Canadians have absolutely free access to all doctor care and hospital care under a so-called single-payer system. In fact, the Canadian healthcare system costs substantially less than the U.S. system, at least in part because if you have a simple publicly administered system, you get tremendous administrative savings. You get rid of all those bills and paperwork and registration departments and surprise bills. You save so much on administrative savings, and we've estimated at about $600 billion annually in administrative savings just from administrative simplification under the single payer. You can then take that money and pay for the expansion and improvement of medical care for everyone.
You know, we heard that clip from former Vice President Biden at the beginning saying that Senator Warren's cost estimates he felt were not accurate. Can we, based on what we know right now and what the cost estimates are, what do you think they are, and what do you think we can afford it?
Well, there have been about 22 recent analyses of the expected costs of Medicare for All. 2 of the 22 have said it would raise costs, but the other 20 either said it would save money or be similar in cost to the current system. You know, in the United States this year, we're going to spend more than $10,000 for every man, woman, and child in this country. It's plenty of money to cover everyone without co-payments and deductibles and give people really high-quality care.
That's what the government's going to spend per person?
No. Total per person is over $10,000, okay? A lot of it's government, but a lot of it comes out of your pocket as your insurance premiums. And I know many of us are used to thinking that our employers pay our insurance premiums. In fact, the money that the employers pay for your premiums comes right out of your compensation. So I still get my health insurance through Harvard. I was a professor there for several decades. And, you know, when they take $8,000 or $10,000 and hand it to an insurance company, that is my compensation that they're paying to that insurance company. It's not some freebie that Harvard or your employer does out of the goodness of their heart.
So Medicare for All is one. We're hearing a lot about public option, which is, and there are different nuances in this public option, but it's considered the more moderate route here. John McDonough, what is a public option in general, and what do you think this means from our candidates?
So Thank you for having me here.
Yeah, thank you
Pleasure
for
to be
coming.
here with everybody and with my guests too. So public option is lower, less aggressive reform than Medicare for All. Some people, going back to the Obamacare Affordable Care Act process between 2008 and 10, actually were big supporters of Medicare for All and embraced public option as a pathway that they thought could lead to Medicare for All in a longer term, because they thought Medicare for All wasn't achievable. And now we're seeing it wasn't able to be politically won in the ACA process. And now we're seeing it come again and again as an alternative to some folks who would prefer single payer / Medicare for All. Public option means that you create a new choice for Americans where they could themselves, voluntarily, themselves or their family, instead of getting private insurance through a private nonprofit or for-profit insurance company, they could make the choice and buy into a kind of a Medicare-like publicly sponsored program where they pay whatever the cost is, however that's determined, and then they get benefits kind of like folks get from traditional Medicare fee-for-service. It is far less extensive, far less reforming the whole system top to bottom as Medicare for All would do, and it would be a major substantive change in terms of the structure. And it's hard to say how it would actually work out until you see the details, because in everything about healthcare, the details are critically important. How would, out of this plan, hospitals and physicians be paid? What would be the requirements in terms of participation? How would it be financed? None of those things are adequately spelled out in any of the candidates' proposals right now, and that's pretty much par for the course in terms of campaign rhetoric. But it is out there. Pete Buttigieg is one of the people Medicare for All who want it, is kind of like saying, let's have a public option. Joe Biden is saying, let's have a public option. I think even Elizabeth Warren, backing off from the adverse reaction she got to her Medicare for All financing plan, now says, well, we'll start with a public option, and then in year 3 of my administration, we'll push forward toward Medicare for All. But so it's lesser, it's weaker T than full-strength Medicare for All, and it is by no means politically a slam dunk that you could do that as well. I was there in the Senate when there was the attempt to do a public option in the version of the ACA, and it could not get all the Democrats together, and Majority Leader Harry Reid had to pull it out. And so there was no public option despite a very concerted and strenuous effort to try to achieve it.
So regardless of whether we're talking about Medicare for All or public option, the candidates are talking about a significant expansion of government health care.
Yes, everybody is.
Everybody's talking about
On
it.
the Democratic side.
So you would think that there's uniform agreement that that is something that might be needed to fix our system.
There's uniform agreement that the Affordable Care Act, in spite of the advances and benefits and achievements of it, does not go far enough in terms of the needs, and that we're seeing critical pain right now on consumers with cost sharing, with the price of prescription drugs, with excessive premiums that the Affordable Care Act did not address. And so there is a demand among particularly the Democratic electorate and independents to go further. And there's an argument within the Democratic Party family right now about how far to go and what that different reform should look like.
Okay. Michael Astrew, public option, Medicare for All, none of the above.
Yeah, I would say none of the above. And I think one of the important things, there's a lot of mind-bending detail in healthcare. And thank you all for coming out and hoping we don't make your eyes glaze over. But I think what a lot of this comes down to is decisions about your healthcare are intimate and they're important to us. And the question at the end of the day is your having choice about many of the most important things in your healthcare, do you value that? Or do you want a brand new, suddenly created bureaucracy out of Baltimore making those decisions for you. So that's the first part. The second thing, which I think people tend to overlook when they start pushing command and control healthcare, is choice is an important mechanism for maintaining quality. The fact that you can leave your doctor, that a practice or a hospital, if it's unsatisfactory, can actually go out of business, is important because there's competition, there's a reason to try to be better. You don't see that in command and control healthcare, particularly in this country. And I think it's instructive. I mean, Medicare relies on private insurance. A third of the patients are picking the HMO option. And the actual operational work is done by private insurance companies, which wouldn't exist under the Sanders and Warren plan. So all of a sudden, you'd have to replace tens of thousands of insurance company employees who do the day-to-day work in Medicare, and you have to go out and you have to hire them, cold. I mean, it would be a disaster in terms of implementation. And when you look at when we've actually had command and control healthcare in this country, it is a disaster. Most of you are not familiar with the Indian Health Service, but it's awful. When I was at HHS, they fought for the right to hire physicians who had been excluded from Medicare and Medicaid for fraud. The VA is not much better in many cases. I don't know how many of you have had experience with the VA system. I had a son injured in Afghanistan. I don't recommend the VA, and a lot of veterans are pushing now to get private insurance instead of the care provided by the hospitals. If you've ever been through military medicine, there's it's bottom dollar. You have no choice. It's truly wretched. And if you look at the countries that are often compared to, this notion that we're going to get everything that's medically necessary is a lie. It's just a lie. And it doesn't happen in the UK. It doesn't happen in Canada. It particularly discriminates against women because one of the categories of disease where they just simply will not provide treatment is autoimmune disease, which is very common. 3/4 of the patients are women.
I'm sorry, there's so much you're saying that's false. I mean, I hate to interrupt you, but I've worked in the VA, I've worked at Mass General, I've worked in public hospitals, I've been in organizations with Canadian physicians. I know the statistics about the quality of care. It's at least as good in Canada as the United States. The statistics on quality of care in the VA shows
I'd like to say my
as good as the U.S.
If you're in Canada or the UK, you cannot get the state-of-the-art drugs for cystic fibrosis, for rheumatoid arthritis, for multiple sclerosis. I've had friends who've died from those diseases because they could not get the drugs in those countries, and you can get them on a regular basis here. Are there access problems in some parts of the system? Absolutely, yes. But the notion that there's this magical nirvana north of the border and over in the UK where you get everything paid for and it's extremely high quality is ridiculous. It's not the fact, and it's not true in the systems that we run here in the United States.
Okay, there's actually a very good study comparing cystic fibrosis care in the U.S. and Canada using registry data with all sorts of information about genetics and clinical factors. Patients in Canada with cystic fibrosis live 50% longer, okay? The death rates are a third lower. So don't tell me that Canadians don't get
I will
good
tell you exactly
healthcare.
that, because that's outdated data.
No,
that you're
it's from the Annals of Internal Medicine last year.
I read that. That's when the report is, but the data is old. Vertex here has created drugs that are effective cures for cystic fibrosis. You can access those drugs here locally. You can't access those drugs in Canada. So don't tell me
Is access,
that you have...
Okay, let's see, Steffi, is access limited in some other places?
Okay, certainly Michael works in the biotech industry.
I don't work in the bio. I've been retired for a long time.
Okay,
So that's another thing.
It's more on top of the precise issues about the drugs that they're producing. But what you have to look at here is what are the outcomes from the population? You don't tell anecdotes to make a point. And there's very good data that we know about Canadians. They live 2 to 3 years longer than we do in the United States.
You can't
2 to 3
just
years
look
longer.
at outcome
They
data
live-
because the populations are not comparable. You've got a much more heterogeneous population in Canada. You don't have the kinds of challenges in many of these diseases that you
But
have
you
in
do
the
know
United
the
States.
population, the average income in Canada is actually a little lower than in the United States, okay? They have a lot of immigrants there, okay? But in most ways, you all know this. You've been to Canada. It's not that different from the United States. But then you look and go, they have a healthcare system that's associated with lower infant mortality, lower adult mortality, lower mortality from serious diseases like cystic fibrosis, lower mortality for people who require dialysis. Okay, you have to look at the data. You can't tell anecdotes about they ought to approve this drug or not. And it may be true. There may be a drug that Canada ought to be approving.
You can't cherry pick the data, which is what
I'm
you're
not
doing.
cherry picking the data. Death rates are not cherry picked. I'm sorry. That's cherry picking the data is saying there's some drug or some procedure that we get in that we get in the U.S. they don't get in Canada, or we get too much of in the U.S. they get the right amount in Canada. We can cherry pick that way, but telling us, what's the infant mortality, what's the life expectancy, that's not cherry pick data. That's the basis on which we ought to be deciding whether it's a good healthcare system or not.
Okay, let's let John come into the conversation here.
I think we should banish the word nirvana, because there is no nirvana anywhere in the world, but there is better and worse. And I would point to one source, which is a foundation in New York City called the Commonwealth Fund, which does terrific studying of the U.S. healthcare system for decades and decades. And they put out a report every few years where they've been doing apples-to-apples comparisons of the United States with 10 other advanced nations, not just Canada or England, but Germany, Switzerland, Netherlands, others. And their most recent ones, they've been comparing 11 countries. They've done this 5 times. The study, you can go on the web and see it. It's called Mirror, Mirror on the Wall. And the one consistency for the 5 times that they've done this study, they look at access, cost, health outcomes, quality of care, everything. The one consistency is that every time they've done this study, when they do their total ranking, the United States comes in dead last. And by the way, in 4 of the 5 times that they've done it, the second worst system is Canada. So there are others. So and people have this idea in the United States that it's a bimodal choice. It's either what the U.S. has or Canada. And the truth is that there are many, many other ways to do it. We confuse the notion of single payer and universal coverage. Every other advanced economy in the world, everyone has some form of universal coverage. They cover 99 to 100%. Right now we're at about 90%, so we have the lowest rate. The other piece that studies have shown consistently is when people are asked how your favorability or unfavorability of your healthcare system, and this is a study in the Journal of the American Medical Association just about 18 months ago, the U.S. comes in dead last in terms of Americans saying that they view this system favorably. So we pay by far the most. We have outcomes on quality and population health measures that are mediocre or poor. We've had declining life expectancy in the United States now for 3 years in a row. We have disgraceful levels of infant mortality, maternal mortality. We have a system that in some fundamental ways is really failing the American public in terms of what we ought to be able to expect from a healthcare system. And so the one thing that I would say, I think we can all agree, we can do a heck of a lot better than what we're doing right now with the results that we're getting from the system we have. Which way you want to go? Canada, my favorite, I think Germany actually has the model that makes more sense than anything else. But the one thing that's clear, we can do so much better than what we're doing right now.
But does an expansion of government's role, will that inevitably lead to maybe less choice for consumers? Because this is the problem, right? We've got a lot of competing data sets, and people don't know exactly which ones to believe. How might broader expansion of government healthcare affect choice and different things in the system? And what do you tell folks about that?
Okay, we have only one data set about life expectancy and infant mortality. Everyone uses the same data set.
But is that going to get people to vote, right? Oh, there's a lower life expectancy, so therefore I'm going to base my healthcare decision on life expectancy, right?
Okay, just want to clarify that concept of choice. If you are a Canadian and you have a Canadian card that you got the day you were born, by the way, and you don't give up to the day you die, if you have a Canadian card, you can go to any doctor in Canada. You can go to any hospital in Canada. You have complete free choice of doctor and hospital. You can't choose your insurance company because the insurance is paid for by your province where you live. But it's good to choose any doctor and hospital. That's the thing you really care about. And, you know, there's an anecdote about Rand Paul when he wanted his hernia surgery, went to the Shoulders Clinic. It's a special hernia clinic in Canada. And he made this big announcement, "Oh, I'm going to Canada, but I'm going to a private clinic in Canada. I'm not using the National Health Program." In fact, if you're Canadian, all you have to do is show up at the Shoulders Clinic. You don't even need an appointment. And they'll see you and schedule you for this special hernia procedure. Probably the best hernia hospital in the world. So people in Canada have the choice that they want. They actually have the choice that you and I care about. We want to choose our doctors and hospitals, right? And my patients want to choose me or not choose me. But they really don't have a choice about insurance companies. And to be honest, none of us really care who pays the bill as long as the bill gets paid by somebody other than me. So, I think really that we need to be very clear about this choice question. People say they like their private insurance, but what they like about the private insurance is the choice of doctor and hospital. They're not that fond of the company that issued that card.
Michael, you mentioned your son's experience with the VA after he came back from Afghanistan. I wonder if you would elaborate on that a little bit, because I think that a lot of us, when it comes to this issue, are going to be looking at it in personal terms. So what personal stories, I wonder, motivate you to study this and to be so well-versed on the healthcare issue and are motivating you as you go forward? Can you tell us a little bit more about your son and his experience with the VA house?
Well, let me actually start with my parents, who are probably more important. I live in Boston because my mother was given the last rites twice in her 30s, and the only place in the country that could treat her was at Peter Bent Brigham Hospital. Under the Warren and Sanders plan, I don't think that she would be able to pick her doctor and pick her hospital and come to it. We moved here so that she could get treated for extremely rare disease. My father died of the same rare brain cancer that got Senator Kennedy and Senator McCain. And so for me, focusing on rare diseases and improving government pathways for people with rare diseases has been part of the mission of my life. So when I was at HHS, I was a co-author of the first expedited drug approval plan, where I said, we were making exceptions for people with HIV, which I was for. I was with the ACT UP people. They were right. But I said there's no moral difference between HIV and other horrible diseases. And that got enacted in 1992. One of the things that was frustrating for me when my father took ill is I had to put him on Social Security disability. And it was long, difficult, and there was a lot of ridiculous paperwork and that kind of thing. I remember saying to one of my employees who was on detail from the agency, "Why does this have to be so hard?" And they said, she said, because it's paper. They can't make exceptions, with hundreds of thousands of people coming through. There's just no way to do it. But I realized when I went back to the agency 20 years later, you could do that electronically. So now there's something called compassionate allowances, where if you've got something where someone's not going to make a recovery, you can get your decision sometimes within 48 hours, usually within a week to 10 days. And those would sometimes take years under the old system because they were kicking everything out to specialists who they could not find and that kind of thing. So it has been very important to me to try to find ways to make government be responsive to the people that are in most need of the help.
Steffi, what's your personal anecdote about what motivates you to do?
Okay. First, I just want to repeat that people in Canada can go to any doctor or hospital. Okay. I also want to repeat that they do have medical innovation in Canada. Okay. It's a smaller country. Maybe there's less than in the U.S. The other thing I want to say is I'm an internist. I mean, I care for a lot of patients who are very, very sick, and I'm all for innovation for new treatments and new therapies because many of my patients can't make it with what we have. So I agree with Mike. We need innovation, and I don't think there's any reason to believe there's going to be less of that under a Medicare For All system. In fact, if you can save money on wasted administration and bureaucracy, you've got additional money to go innovate and do some new things.
Well, you interrupted me, so let me say something.
What the story or
if
not?
I were in
know.
Canada,
Yeah.
I would not have been able to walk up those stairs. I would have had to been pushed up in a wheelchair because the Canadian government will not pay for the medications for people with serious autoimmune diseases. And so this notion that you can get whatever you want in Canada and there's not going to be any difference in outcome is ridiculous. If you have multiple sclerosis, you have rheumatoid arthritis, you have cystic fibrosis, you have any number of rare diseases, you cannot access the drugs that you need in order to maintain your health. And that's a fact. And waving your hands and saying, well, overall, the outcomes are better in Canada, when there's a lot of things that go into that in terms of lifestyle, smoking, drugs, all kinds of things go into mortality.
Mike, let's let Steffi respond and tell us her story.
With all due respect, the pharmaceuticals are not part of Canada's single-payer system. Pharmaceuticals are provided through a private system. Now, under Medicare For All and the Sanders or the Warren bill, we would incorporate pharmaceutical care into the single-payer. But your issues about pharmaceuticals in Canada are really not entirely relevant since pharmaceutical care is private in most of Canada.
No, that's ridiculous.
Okay, I'm gonna
untrue.
Okay,
Absolutely.
I'm going to actually talk a little bit about, no, that's true. That's true. I'm sorry. I'm going to talk a little bit about what motivated me. I am a physician. I got very well educated. I learned about all sorts of wonderful things that I could do for patients. But I found, like many physicians do, that the health finance system stands between me and getting those things done for patients. So patients don't come in when they get symptoms. They get worse. Sometimes they die because they didn't come in, okay? People come in to see me, and I tell them I want you to start this medication, and they say, Doc, I just can't afford it. Can you come up with something cheaper? Sometimes I can, sometimes I can't. If I prescribe stuff that's too expensive for them, they don't come back because they don't want to have to tell me. It's embarrassing that they couldn't afford to do it. I've done research involving patients who show up at private hospitals in emergency situations, get dumped, placed in an ambulance, and transported somewhere else because they don't have insurance. I've treated a lot of immigrant patients who really have very poor access in most states to Medicaid and public services. So my own experience is of seeing patients who need care, who I could really help, but who can't get that care because the healthcare system got in the way. And a particularly poignant case was a 47-year-old truck driver, no health insurance, 3 children. He was having horrible pain in his chest and upper abdomen, stayed home for 3 days with this horrible pain, couldn't take it anymore, came to the hospital, and we found that he had had a heart attack, a myocardial infarction. Certain locations of heart attacks can give you pain here rather than here, right? By the time he came in, it was too late to give him the clot buster drugs that could have saved his life. He died in the hospital, and at autopsy, we went to the autopsy conference, we looked at his heart, and we literally held in our hand the heart of a man 47 years old who could have been saved if we had a better health financing system. So, there's lots of stories like that. There's thousands of stories of people in this country dying because they don't have health insurance. And we know of a system that lets us all get access to care that's cheaper than what we have now, that saves on administration and lets us transfer that to actual patient care. And that's what we need to be working for right now.
Okay. John McDonough, what's your personal story about why you're involved here?
It's less dramatic than Michael and Steffi. I got elected to the Massachusetts House of Representatives in 1984, representing the Boston neighborhood of Jamaica Plain, Roxbury, Dorchester. And when I was picking committee assignments, somebody suggested to me, why don't you go on the healthcare committee? Because there's nobody from Boston on, and you can be the Boston voice on healthcare. And I said, that's great, but I don't know anything about healthcare. I don't know Medicare versus Medicaid. They said, don't worry, we'll teach you. And so I took it, and I just fell head over heels in love with health policy. The first issue I took on was lead poisoning, particularly lead paint poisoning. And it was a very dynamic period in Massachusetts when Michael Dukakis was governor. There was a push for a universal health care law that actually passed but never got implemented in 1988. And just learned an extraordinary amount about how complicated, how challenging, how unfair our system was. We had about 700,000 people in Massachusetts who had no health insurance. The numbers were growing. It was a national problem, and it was an urgent issue that needed to be addressed. We thought we would get it done really fast. It took a long time. In 2006, I was running Healthcare for All, the advocacy organization. We were part of the effort to create the law that's now called Romney Care. We got the rate of uninsurance in Massachusetts down to the lowest of the 50 states, and it's pretty much stayed there. We're still by far the lowest of the 50 states, and we helped to establish some of the models that got translated into the Affordable Care Act. And this is a journey. That's one of the things that I've learned over 35 years. This is a journey. It doesn't get solved in one single action. It doesn't get addressed all at once. It takes time, effort, consistency. And one of the benefits of Massachusetts is there's a lot of folks like Steffi and many other folks over years have been working so hard on this and continue to press and push forward wherever the need appears the most great, and we keep at it.
Mike, I want to ask you, when we heard stories like Steffi's about patients who couldn't get health care, and yes, you say that you want choice here in this country, but I wonder about choice being restricted by finances. And I think that's what a lot of people are worried about in this debate. Folks say that they want their insurance because they're concerned about what might happen if they don't have it, but they're also concerned when they see these increasing costs and all of a sudden you get a $400 bill from the doctor. So is choice a false promise in a way? Is it only for those people who can afford it? And are drugs for certain conditions only for people who can afford it? And with increasing income inequality, are more Americans going to look at this and say, am I going to be able to afford my health care? So is choice real, and will it stay real?
I certainly know we've got lots of problems with the status quo, and I'm not a defender of the status quo. I'm probably closer to John than to Steffi, because I agree that Massachusetts, I think, was on the right track, and that we've been a leader here, and that we've almost at the point of getting full coverage of people here. And it looked to me at one point in time like that was going to be a national model, and it would take some time to get some other states up to our level because they didn't have the kind of infrastructure in health that we had here. But I was optimistic for a while, wrongly, that we might be going in that direction. So I think that our problems are solvable, that we can create a system with universal access and maintains a wide amount of choice. And that should be the goal.
And would it be a government-run program that would give?
No, it would be a blended thing. It would be just exactly what Governor Romney originally was aiming to do, and pretty much we still have here. And it's a blend of federal, state, and private programs. And I think that's where you have to go. Healthcare is extremely complicated. There is no single magic bullet answer to it.
I think the thing to understand, though, is that when people say choice, people mean different things. So I think from Michael's point of view, it's want to make sure you have a choice of your health insurance company, even if the differences between them are sometimes really hard to see. And I think for Steffi, it's choice of hospitals and physicians. My sense is that most people actually, when they get down to it, care a lot more about having a choice of hospital and doctor rather than a choice of insurance plan.
I'm there. I mean, I don't think people even know who their insurance companies are most times. And I think, this is one of the things my former boss, President Obama, found out, that people care a lot about picking their own doctor and hospital. And in most socialized medicine situations, you don't get that chance.
Okay.
And in the UK, you don't get that chance. And, up until fairly recent.
But you do in Canada.
Interrupt me.
Yeah, you do in Canada.
If you were 55 and you had renal difficulty, they explained to you that it was your duty to die because they
That's
didn't
not
give
true
dialysis to
That's
people
not true either.
over the age of 55.
Okay, that is simply not true. Okay.
Well, let's talk about the Republican plan. Is there one? What have we heard from the Republicans on this? We've got public option and Medicare for All for the most part for the candidates on the Democratic side. We know that President Trump wants to repeal Obamacare, or the Affordable Care Act. So what does that mean, John?
Well, so there is no Republican plan right now. Some people may remember about 6 months ago or so, President Trump promised that he would have a plan out in 2 weeks. That's his big tell. Whenever he says 2 weeks, it's not going to happen. And there was an effort in 2017 to repeal and replace. Ultimately, there was no final plan that people voted on, and it fell apart and it didn't pass. All we can judge President Trump on right now is the actions actually that the administration has been taking. And frankly, most people don't see it because they don't follow it that closely, but there have been a lot of significant activities by the administration since the failure of repeal and replace that are worth understanding. In the Medicaid program in particular, the administration has been encouraging states to require people who qualify for Medicaid to have to meet so-called work requirements if they fit into certain requirements. And so if you can't demonstrate that you're working 80 hours a month, then you lose your Medicaid coverage. That's one thing. Another thing we've seen just today coming out of the administration is encouraging states to transform their Medicaid programs into block grants. By the way, most of these things are actually, we believe, illegal and violations of the Social Security statute. But block grants is actually a real problem in terms of guaranteeing access and ability to get the care people need. So very deep concerns about that. On the private coverage side, we've seen a series of activities by the administration. To try and undermine one of the central reforms in the Affordable Care Act, which is the elimination of the ability of insurance companies to rate customers based upon their medical histories, and to prevent insurance companies from imposing pre-existing conditions. President Trump would have you believe that he is the #1 proponent of not allowing pre-existing conditions, but in fact the actions of the administration in terms of undermining those central protections of the ACA is evident in terms of their policies on something called short-term coverage, in terms of allowing something called association health plans, and in terms of a whole new mechanism that they're putting in place just this month through regulation in terms of individual coverage health reimbursement accounts. I know I'm throwing a lot of gobbledygook at you, but it's just all of these provisions are attempts, without people really understanding what's going on, to undermining that central provision of the ACA that the American public deeply appreciates and deeply respects, which is getting rid of the ability of insurance companies to impose pre-existing conditions based on your medical history. That is very much at risk in terms of the actions. So while they don't have a plan, don't judge them by what they say, judge them by what they're doing, and they are attempting to weaken and undermine the central advances that have been made under the Affordable Care Act.
Could it also increase anxiety about expanding the government's role in healthcare? I don't know who's going to come in office next who may be able to affect my healthcare with all of these things that you're talking about right now.
Okay, well, in general, universal entitlement programs like Social Security and Medicare that everyone's eligible for, everyone's eligible for at a certain age, those have been very hard to chip away at because the constituency that supports Social Security and Medicare probably includes all the people in this room. If you have these special programs where you segregate and isolate poor people, those are very easy to erode and chip away at if you're a conservative politician. So one of the big advantages, frankly, of Medicare for All is that you put everybody in the same lifeboat. So if my health care is identical to that of that homeless guy on the street, I'm going to pay a whole lot more attention to making sure that his health care is good, right? And the politician can't come in and say, let's get rid of homeless health care because he's homeless. No, that would be getting rid of the quality of my health care too. So I think that's a really important political lesson. And frankly, what's wrong with doing a little federal and a little state and a little private and a little out of pocket, it puts Americans in different lifeboats depending on what kind of insurance they have and how much money they have. And then you really are vulnerable when a conservative politician comes in to him just pushing over the lifeboat of the poor people.
I would put a slightly different spin on it. I think the entitlements have been fairly untouchable. I agree with that. But what I would say is, and this is important, I think, for healthcare, is you look at Social Security, what the Congress has consistently done is not provided enough administrative costs for the most complicated and difficult programs, which are disability. So now, for instance, you have over 1 million Americans waiting for a disability appeal. And that's really a function of the fact that Congress doesn't like paying for administrative costs. They're boring, and it's easy to take those savings. And what happens is that services degrade because you just don't have the people and the support to do them in a proper way. And you see that in most of the command and control healthcare systems around the world, that the government, it's happening in the UK now, where not only have they taken a lot of the high-end pharmaceuticals and say, you know, tough luck if you have cystic fibrosis or multiple sclerosis or RA, but there are about 60 of fairly low-cost routine pharmaceuticals that they just can't provide on the ground because they can't get their act together administratively because the administrative budget is so tight. You know, it's contraception, it's, you know, lots of antibiotics, relatively cheap pharmaceuticals you can't get today on the ground floor because the administrative system is so paralyzed.
I just want to keep reminding, because Stephanie and Michael, it's the United States, it's Canada, and it's England. And there's a lot more choices out there than just those. Let me give you just one example of Germany.
You put Germany out there.
I have a friend who's a member of the German parliament. He's in the Social Democratic Party, and he was over for a visit just about a year and a half ago. And I asked him, because it was the time of year, early in the year, when all the drug companies are raising their prices just en masse. And I said, so in the German system, which is a really interesting drug price control system called AMNOG, I asked him, I said, how do you deal with annual price increases by drug companies? And he said, they're not allowed. They're not allowed. And the truth is, if you go to almost any other system or any advanced country where they regulate drug prices, annual price increases don't happen. You can't get a price increase in Germany unless you can go and demonstrate some greater clinical benefit from your pharmaceutical. And so there's other ways to do this that are really smart and that give a better system than what we have right now.
But I would expect that the argument against that would be, well, is there innovation then? Because that money goes toward making new drugs.
Yes, there is innovation, because in the German system, when a new drug is introduced, it gets rated by an independent research outfit, which has a lot of national respect and integrity. It's not controversial. It's called IQWIG, IQWIG, a German word with about 300 letters that I can't pronounce. And they classify a new drug. They take all of the evidence, including from the drug company, and they rate it. They say, this is highly innovative, this is medium innovative, this is kind of innovative, not much, but it's an innovation, or it's not innovative. And if it's not innovative, it goes into what's called a reference pricing, where it gets paid like a generic for what's out there on the market. And if it's a highly innovative drug, then it gets a very high price negotiated between the drug companies and the insurance plans called the sickness funds. And that's a way to do it. So they reward innovation. They say, bring on your innovative. But what they won't do is they won't allow drug companies to charge sky-high prices for drugs that add no clinical value to what's already out there in the market. And that just seems to me to be really a smart way to do it.
I substantially agree with John. I do agree that Germany, if you're looking at a European model, is the one to look at. I think drug pricing is more complicated than that, because one of the things that happens because of the inability to do increases is they ask for higher prices initially. And so it is sort of a wash. And in Japan, it's much higher initially. So
yeah, I don't think it's a wash. If prescription drug prices are 1/2 as high in OECD nations as they are in the U.S. 1/2, so it's not a wash. They still get their drugs at half the price. Now, maybe you're saying they ought to negotiate harder and get even lower.
I don't think.
Yeah.
Most of the innovative drugs actually initially are more expensive in the other major countries than they are in the United States.
But on average, overall, prescription drug costs in other developed nations, remember the OECD, and most of them are Europe, but it's also Australia and Canada, average prescription drug prices are half what they are in the United States.
I would like, so we don't get into the statistic debate, I would like to open it up to questions from our audience, because I would like to have time to be able to hear from folks who may have questions as they are trying to make up their minds about how to vote and how to deal with this particular issue. So we have someone who has a microphone in the audience, a staffer who has a microphone. So if you have a question, raise your hand and he will bring you the mic. Over here? Oh, over there? It's closest? Okay.
Hi, so I have a question.
If you could just say your name and speak up a little bit. Yeah.
Sure. I'm Brandon Green. I have a question for McDonough and for Astru. For Professor McDonough, could you explain a little bit more about the actual mechanics of the German system to help us understand how they govern the insurance entities that are there, and maybe speculate as to why that isn't being discussed on the campaign trail by any of the major candidates? And then for Commissioner Astru, thank you for the service of your son. And what would you do to fix our system, and why are the Republicans putting forth any other practical ideas apart from just tear down the ACA?
So do you want to know about the German drug system or the German system more generally? So the German system is quite interesting because it's 100% private health insurance. Just like, well, it's even more private than the United States. However,
not exactly. It's social insurance, which is sort of a hybrid between private and public.
Yeah, but it's
not like U.S. private insurance.
No, it's not. I'm not saying
social
that.
Insurance.
I'm not saying that. But it is private insurance companies called sickness funds. There's about 200 of them, and unlike in the United States, they are tightly, heavily. First of all, they're nonprofit, so they're not out to make huge amounts of money. And they are significantly regulated in terms of how they operate and their premiums and the public satisfaction with the system. I'll tell you something about Germany. The interesting thing about Germany right now, they've been reforming it for the past 20 years in a serious way. And right now in Germany, health policy is boring. it doesn't get people arguing and fighting with each other because they've kind of figured it out. And it works well, and nothing's perfect. There's always issues that arise, but they've really figured it out. They've figured out dealing with prescription drugs. They've figured out dealing with rising costs in a system that is mostly private with strong government regulation and control.
Michael?
So, a few things. Let me mention pharmaceuticals. So we done an important fix in that we fixed our patent system, because one of the reasons that too many of the drugs were too expensive for too long was because we were under the old patent system, which allowed coverage almost indefinitely if your lawyers were good enough. And that's wrong. And now it's 20 years from filing. It takes 12 to 15 years to develop a drug. It means that most of these innovative drugs, which are expensive in the beginning, are not going to be expensive for very long. If you go back and look 10 years ago, governors and Medicaid agency heads were complaining about Gleevec. Nobody complains about Gleevec anymore. It's off patent. So I think that's a big thing. The FDA and Congress have not gotten serious about biogenerics. A lot of the most expensive drugs are biologics. I think that we've got to start treating biologics pretty much the same way we treat chemical entities, and I think that would bring down the costs of insulin, erythropoietin, the interferons, and a lot of the drugs that are, I think, in my opinion, higher costs than they should be. On the insurance level, I mean, I think one of the things that has always surprised me is and sometimes this is state law, it's all one-year contracts, and it seems to me that has a couple negative effects. An insurance company ought to have a vested interest in your long-term health, and if they're only in on a one-year basis, I don't see that relationship happening. Also, at a visceral level, when I was a CEO, there were basically 3 insurance companies at the time in Massachusetts, and we got a great deal, the 1 year from one company, and then we came in the next year, and it was 5 times as much, and we couldn't get a bid from the other 2. So I did, of course, what litigators do. I called up the CEO of one of the other companies and said, look, this is an antitrust violation. If you want to argue with me about this, you can. Otherwise, I need a bid here. And I got the bid, and I got our costs down. But I do think that we need to develop a longer-term relationship with our insurance companies that also takes care of some of the other problems in terms of pre-existing condition. Not a full answer, but it helps. So I think there's a lot of incremental things that we need to do, and that's typically what works in healthcare in this country. I was working for Secretary Otis Bowen in 1986. Most of you were probably, 86, 88, most of you were probably not following healthcare terribly carefully there, but Bowen came in wanting to do one thing, and he got it passed, which was added long-term care for Medicare. And then older Americans started seeing the bill, and they revolted. And in fact, there were spectacular photos of elderly Americans attacking the car of the Ways and Means Chairman, Dan Rostenkowski, in Chicago, even sort of moving it like they were going to turn it over. And Congress panicked, and 3 weeks later repealed long-term care. So I think, we weren't braced for the cost. There wasn't a constituency for the cost. We hadn't done the homework to brace people for the changes. And that's what happens if change catches Americans by surprise in the healthcare system. And I'm really concerned that what several of these candidates are talking about is change that would be so dramatic that there would be this kind of reaction, and there would be chaos in the meantime trying to sort things out, as there have been with a lot of the features of the Affordable Care Act.
I don't know. Americans have a lot of experience with Medicare, and we have a whole Medicare bureaucracy. I'm a little confused about these predictions of chaos if we have Medicare for All.
And basically, I just want to make sure that we have it clear. Your plan, what would you do differently, is you would keep private insurance, but maybe longer-term relationships with insurers. And in terms of drug prices, what would that mean? Would that mean giving the government the power to negotiate, Medicare prices for pharmaceutical drugs, or what would we do about those?
I think that you can talk about some of those things. Right now, there is some power, and Medicare can decide whether to cover or not. And they have some discretion, not as much as some people think they ought to have. And, you know, I think that's something that you can talk about. But I think if you move to a system where you abolish insurance companies, which is the Warren and Sanders plans are very explicit about, aside from the fact that a large part of the current Medicare population won't be able to access the care that they have now, you literally have nobody to run the program. People don't understand that what the people in Baltimore do is they set policy. The actual day-to-day running of Medicare is done by insurance companies through 63 or so separate contracts. If the insurance companies go away, one of the things that means is that that whole very established bureaucracy over a century, half a century, disappears, and all of a sudden you have to go out and you have to hire, you know, under civil service rules and all that kind of stuff, a much more expensive infrastructure than what you have now.
Go ahead. Quickly,
Okay,
though. I want to get one more.
Okay, I mean,
questions.
overhead on Medicare, traditional Medicare, and 2/3 of Medicare enrollees are on traditional Medicare. Overhead's less than 2%. Okay? Overhead on Medicare Advantage programs, the private managed care plans that subcontract with Medicare to cover seniors in restrictive networks. Average overhead, according to the Government Accountability Office, is 13.7%. The difference in administrative costs is actually huge, and it's, you know, in fact, part of why traditional Medicare can be administered simply is it's a simpler system. Every doctor who's willing to take the fees is automatically in Medicare. Every hospital that's willing to take the fees, which is actually essentially all U.S. hospitals, is automatically in Medicare. You don't need a referral in traditional Medicare. You know, there's problems with traditional Medicare. It doesn't cover enough. There's gaps in the coverage. But it is simple, and the simplicity means that you can save literally hundreds of billions of dollars a year just on the insurance administration if you go to a single-payer system and take those hundreds of billions of dollars and use them to improve care.
Okay, let's go to another question. Yep.
So I'm wondering how much, and it was very interesting to hear about the German system, but how much of the profit motive is part of the problem in healthcare? Because you've got these insurance companies and drug companies who they're there to make a profit, not necessarily to make people better. And they spend an enormous amount of money lobbying to make sure that they can keep their profits up, instead of, again, focusing on, you know, what can I do to make people healthier? So I'd like to get your feedback on that.
And John, let's start with you. I think you dealt with a lot of folks who were lobbying when you were helping with this legislation on both the state and the national level. What do you say about that?
I wrote a commentary about 2 years ago for the American Journal of Public Health, and I titled it Our Greedy Healthcare System, because I think more than anything, greed characterizes what drives this system. This is so much about money. Let's just take the issue of electronic health records, which is driving physicians crazy. And there's actually an interesting thing about the Veterans Administration and the Indian Health Service. They've got lots of flaws, lots of problems, lots of challenges. But one of the things they have is they have a medical records system, electronic medical records system, which for the most part, the people who use it actually like it pretty well, versus the rest of the system where people look at it and the physicians, my sister-in-law is a physician in Oregon. She quit physician practice because she couldn't stand going home every night and doing 4 hours of entering records. It just drives practitioners crazy. And there's a fundamental difference between the electronic health record system for the VA and the Indian Health Service versus the rest of the system. The electronic health record system for the rest of the system is not about helping patients. It's not about helping providers. It's about billing. It's about making sure that every provider system gets the maximum amount of revenue through upcoding and all other kinds of freaky adjustments that they're able to do to get as much. And that really characterizes, I think, our whole system. Elizabeth Rosenthal wrote a book a couple of years ago called An American Sickness. And it is very effective characterization of how this system has gone off the deep end in terms of the profit motive driving everything. And there's just been something, even the nonprofit organizations to survive now have to really resemble as much as they can stockholder-owned companies that they exist, according to Milton Friedman, for one reason, and that is maximum return to shareholders. That's what's driving our system, and that is a fundamental difference, I believe, between the American system and every other system that we see in advanced nations. That's fundamentally what's different, and fundamentally, I think, what is deeply wrong with our system.
Yeah, no, I would agree with that, profit-making, investor ownership is a very destructive force in a healthcare system. I want to talk a little bit about physicians, because people say, well, the physicians are greedy too, and certainly there's some of that. But in fact, physicians have, there's been a lot of physician support, particularly recently, for the idea of single-payer healthcare. My own group, Physicians for a National Health Program, we've got about 21,000 members, but we're a single-issue organization, and that's all we do is advocate for single-payer health care. But more significantly, I think the nation's largest medical specialty society, the American College of Physicians, I'm a member, and maybe other people in the audience are, it's an internist. American College of Physicians has 159,000 members, and it just came out and endorsed single-payer Medicare for All. Now, they endorsed something else, too, called public choice. I don't even know what that is, but they also very explicitly endorse single-payer Medicare for All. So I think many physicians are finding, like I am, that they can't provide for their patients, that they prefer a nonprofit system, one that was simple and didn't have all this billing-related paperwork and computer documentation.
I think it's pretty easy to try to demonize a large group of people. If you look here in Massachusetts, most of our insurance companies are in fact nonprofits. And in a lot of the country, that's true. And the for-profit insurance companies, you know, the performance is not that much different from the nonprofits, in my opinion. And likewise for the hospital chains. You know, there are some advantages, for instance, to being publicly traded because of the transparency that's required and the regulation that's required and the requirement to tell the truth and that kind of stuff, which you don't see on the nonprofit side. And I've seen some pretty horrible stuff occasionally on the healthcare side, on the nonprofit side. So I think I understand why people feel that way, but personally, I think it's a simplistic analysis, and you have to be careful about that.
But you don't think that money is a primary factor in our healthcare system?
Well, I worked with a lot of these. So there are bad apples in every setting, but most of the people that I know in healthcare, in hospitals, and in the biotech companies, they're mission oriented. The money is not that important to the vast majority of them. Are there the people that finance the companies? Sure. The venture capitalists? Absolutely. Investment bankers? Absolutely. But for the
Private equity?
Yeah, private equity, fine. But if you're talking about the people who are making the day-to-day decisions, a lot of them are physicians. A lot of them take their oath, very seriously. And I think it's a mistake to say just because they're in a profit setting that automatically they're bad, automatically they're part of the problem. I think you have to look at the performance, and I don't think that you can...
I didn't say they were bad.
Yeah.
I said they're motivated by profit. And to the point is, I'm not making a moral judgment. I'm saying, because I'm an economics person.
Yeah.
So I understand that the concept of if you're a business and you're supposed to make a profit, that is your goal. What I said is the goal of the companies is to make a profit, not to make people healthier. And I think that's my point. I'm not making a moral judgment as to say they're bad people, but they're set up. That's their job. It's to make a profit. If they don't make a profit, that CEO gets replaced, right? He doesn't get replaced if the healthcare of patients isn't good. He gets replaced if he doesn't make quarterly earnings numbers. And that's a fact.
Yeah, but a lot of times the interests are congruent. Certainly in the biotech industry, the things that you do to make money are the same things that you do to do the maximum benefit for patients. there isn't that much tension. I agree that there's more tension in the hospital area, and sometimes corporations do compromise on that kind of thing. But you see the same temptations in nonprofits too. I mean, I've had some bad personal experiences with some nonprofit hospitals. So you have to be careful. I don't know that the profit motive descends terribly far down in most of these hierarchies. I think mostly you have people who by self-selection have decided to be healthcare professionals, and that's what really motivates them.
Well, I mean, again, I just respectfully say, my wife's a physician, right? Her practice, venture capitalists came in and they wanted to take it over, and they're trying to monopolize the dermatological practices in Massachusetts. And their goal isn't to make, dermatology better in Massachusetts. It's to make money by getting monopoly hold of the practices, and they're willing to cut her a share so they can get a monopoly hold of this business. They know nothing about dermatology.
Right.
Yeah,
And a lot of the surprise bills from emergency rooms are directly related to private equity coming in and buying up the practices of emergency room doctors. So the private equity has taken a situation and making it so much worse. They're there to raise the prices to make a quick buck and get out of there in 4 or 5 years. And I think a lot of patients and doctors who want a good system are going to get dragged down by it.
Right, we're gonna try to get some more questions in before we run out of time here. Another question in the back. Sorry, but we gotta keep going. We can talk a little bit after, but I want to make sure that more folks get their. We've got more hands up. Go ahead.
Thank you, and thanks for a very entertaining discussion. My name's Danny, by the way. My question is actually kind of a little bit more of like role playing, to be honest. So each of you have different stances on kind of like what's being proposed as like a healthcare option by the candidates. So if you were a candidate who held the opposite belief of what you believe as a person, how would you as a candidate reach out and kind of convince someone who holds your beliefs that your option is correct?
Well, I would probably say what John's saying, because I think he's a pretty credible, persuasive guy. Because people do have concerns about access, and people want to be optimistic that reform can address a lot of these problems. But the problem is it is really complicated, and the history in this country is that when you do something in healthcare that's not incremental, things tend to fall apart. And that's what we saw in the Affordable Care Act. That's what we saw with long-term care in Medicare. That you really need to build a consensus. And it's one of the things that maybe the last time this happened in healthcare is when we extended the drug benefit in Medicare, and we got a bipartisan coalition of people to support it. And there was some resistance because it meant a lot of disabled and older Americans were paying a bill that they weren't paying before. But it was a good thing, and we got it through. We need to do more of that. We need to have more bipartisan cooperation, and we need to move incrementally in ways where we're pretty sure that the American people are going to support what we're going to do.
With all due respect to your answer, saying that we need more bipartisan support.
I'm sorry, I can't hear you.
Wait till we get some.
With all due respect to your answer, focusing on the fact that we need bipartisan support doesn't highlight any aspects of a Medicare for All plan, which you as a candidate would be proposing to someone like who holds your personal beliefs. So is there anything within the Medicare for All proposals that are out there that you could use to convince somebody who's saying, hey, no, we don't want anything?
I have to confess at this point I'm confused as who's supposed to be persuading
talking.
whom about what.
Yeah.
I'm supposed to be role playing, and then I've kind of lost track of really what I'm supposed to be saying, responding. I don't mean
So
to
are you saying, does he find anything redeemable in Medicare for All that he would use if he were a candidate running, even if he didn't necessarily agree with it? Okay.
Yeah, I think that what I would say is Medicare, the reason Medicare was picked, and it's not Indian Health Service for All or Veterans Administration for All is because people have a relatively good opinion of Medicare. I don't want to overstate that because Medicare has lots and lots of problems. But what I would do as a candidate is say, well, you love Medicare, we're going to have more of it. And I would keep it very simplistic. And to some extent, that's actually kind of what we're getting from a couple of the candidates because they don't want to sweat the details. And when the details started getting sweated by interest groups in the media, Senator Warren had to go back and redo her plan. So, kudos to the media and some of the groups for asking, the hard questions at the right time. But in general, rhetorically, the left has done a very smart thing in focusing on Medicare and saying Medicare for all, because Medicare is very popular. But the truth is, if you extend it to all Americans, it's not Medicare anymore, because Medicare depends both operationally and in terms of choice of service on private insurance companies. And you go to Medicare for All, you take away the private insurance companies. So it's going to be something different. It's not going to be Medicare as people know it today.
Okay, we're out of time, unfortunately, but I'm going to give each of you a closing statement, but that means one statement. And what is your advice to the voters as they consider this very complicated issue and they consider the candidates? What advice do you give them to make sense of this going forward and to be able to cast an informed vote? John McDonough, you first. Sorry.
It's complicated. It's not easy. People don't understand health reform. People don't understand the system and just kind of deal with it bits and pieces as they need to deal with their life needs and their life crises and for themselves and their loved ones. It's important to pay attention. It's a really valuable, important conversation that's going on. It's touching a lot of different pieces and elements that people maybe have a hard time getting or being able to stitch together. I think that I personally would take Medicare for All in a heartbeat. I also think that looking ahead very realistically and politically, I don't see it happening in 2021 because I don't see in any way, shape, or form coming close to what would be needed in the United States, even if Democrats controlled the White House, the Senate, and the House. And so I think it's important to be strategic. And quite honestly, my priority, I think the most important priority in 2021, if there is a new government that we're dealing with, is to aggressively throw everything we've got into the fight on climate change. Because frankly, I think this is terribly important, and I agree and admire Steffi in so many ways. But if there's an urgent imperative in terms of public policy, the house is burning down, folks. And we need to focus. We need to be strategic and understand what is most urgent for us as citizens and as human beings.
Okay. Steffi, your advice to voters?
Okay, I would definitely deal with climate change, but I think you can do more than one thing at a time. And in fact, in the mid-'60s, when the very dramatic change of Medicare and Medicaid was enacted in 1965, there was a whole slew of legislation. There was immigration reform, there were civil rights given to women, Title X, there was the National Endowment for the Arts was founded. There were huge changes that happened at once. Now, it did involve the Democrats winning a landslide election. Okay.
How many votes did they have in the Senate?
But you can, you can change things. And I would just remind you, you can't get across a chasm in two jumps. Sometimes it's easier to go for the thing that'll work than to take a halfway measure that's going to fail. And the whole secret here of getting to really universal comprehensive coverage is simplifying the system into the single payer system that gives you the administrative savings and gives you the money to pay for the rest of what you need to do in terms of health care.
Okay. Michael, advice to voters?
Well, I'm more parochial than my friends to the left, so I would stick to health care. And I would simply say, I understand what you're trying to say about expanding access. That's a good thing. I'm concerned with expanded government role, that there will be less choice and that quality will decline. I'm not hearing very much from you or any of the candidates about how to maintain choice and quality. What can you tell me about that? So asking that fair and hard question, I think, is the most important thing that voters can do.
Okay. I want to remind everybody, as long as we're speaking of climate change, this is a great segue. Next week, February 4th, our next in our Get Educated series is about climate. And WBUR Earthwhile reporter Bruce Gellerman will be moderating a panel of experts, and you can register online. It's a free event, wbur.org/cityspace. Thank you very much, John McDonough, Steffi Woolhander, Michael Astrew, and thanks to all of you for coming tonight.